any clinical situation, our priorities are always going to be the same. A, B, C. Airway, breathing and circulation. So it's our prime duty to make sure our patients have a clear airway, that they're breathing and that they have an adequate circulatory system. These are the essential life-giving physiological processes which must be ongoing to maintain life. If any one of these is interrupted, then the patient's going to die fairly quickly. They're absolute priorities: airway, breathing and circulation. And sometimes you can assess someone's ABC in just a few seconds. If you look at someone and they look back at you in a meaningful way and they talk to you, that means that the airway is clear, it means that they're breathing, and if they're looking at you, it means their brain's probably working quite well, and you can just see the perfusion of blood in their face. You know that A, B and C are intact. So it could just take a few seconds. And that's always the priority, is to make sure that A, B and C are functioning properly. And it's also worth thinking about in the most difficult of clinical situations. You might go into a situation where there seems to be an awful lot to do all at the same time. There might be obvious deformities. Limbs might even have been amputated or torn off. There might be blood all over. You think, oh, where do I start in this situation? It's an overwhelming situation. What do I do first? Well, all you need to do is just pause for that split second and think, my priorities are A, B, C. Let's check the airway. Let's make sure they're breathing, and then let's go on to the circulatory system. They need to be assessed first. And just before we look at these in more detail, I want to point out something that's obvious but of critical importance. And that is that the ABC assessment is not a once-only assessment. So we don't check the patient's airway, breathing and circulation when they first come into the department and then assume it's okay again. We need to be constantly reassessing it. So especially in a badly traumatised patient, we don't want to leave them alone. Someone should be with them, and we are constantly assessing that their basic physiology is functioning to maintain life until definitive care can be given. So let's take this ABC and elaborate it a bit now for the trauma situation. In the trauma situation, we add a little bit and we add a couple of extra letters. So A is for airway and cervical spine protection. They're the first two priorities. B is for breathing and ventilation to make sure the air is going in and out of the patient's lungs. C is for circulation, and we add hemorrhage control. We want to stop any bleeding. D is for disability. Does the patient have a neurological deficit? It's a neurological examination. E is for exposure. The patient should be fully exposed so we can see all of the surface of their body to assess any possible injuries. E is for everything else, and E is also for environmental control. We don't want traumatised patients to get too cold. And the other thing that can be a little confusing is, what do we do first? How do these things link together? Well, life-threatening conditions should be treated as they are identified. So if we identify that the airway is obstructed, we clear that first. Then if we identify that the patient is not breathing, we then ventilate them. Then if we identify there's a problem with circulation, there might be hemorrhage control, or it might be that the patient is in cardiac arrest, we deal with that. So we identify problems as we go down the A, B, C, D, E hierarchy, the A, B, C, D, E prioritisation of care, and we deal with the problems as we come to them, going down A, B, C, D, E in that order. So let's think about A first, airway with cervical spine protection. So if someone's traumatised, they may be, for example, unconscious. They may have a reduced level of consciousness. Now, if you put your head down on your chin like that, Just try it. Put your head down on your chin. And if you take a deep breath, can you take a deep breath with your head down on your chin? Well, yes, you can. You can. But the reason you're doing that is you don't realise you're doing it, but there's actually muscles in your pharynx and in the back of your tongue which are keeping your airway open. It actually depends on voluntary muscular activity. It's just that you don't realise you're doing it because you are conscious. But if someone's unconscious and the head goes down like that, that will close off the airway. So something as simple as the position that the patient's head and neck are in could close off the airway, causing asphyxia because it blocks off air. Or they could be trauma to the neck or mouth, or foreign material could be stuffed in the mouth. There's different things that could block off the upper airway. So what do we need to do? Well, it depends a bit on the history. Normally, in a medical situation, we would say that you put the patient's head up, the chin extension. What's sometimes called the sniffing the morning air position. We put the patient's head up. But of course, in trauma, the priority is not A, the priority is A with cervical spine control. And the spinal cord goes through the vertebrae, the cervical vertebrae in the neck. And it's quite possible that the vertebrae have been fractured. There's a break in the vertebrae, but no displacement. So you could have broken vertebrae, but no displacement. But then when you put the patient's head up, or move the patient's head from side to side, that could actually tear through. The broken ends of bone that are sharp could actually tear through the patient's cervical spinal cord. And that changes a significant vertebral injury into a catastrophic injury, because the patient will never feel or move anything below that level again if they have a transverse spinal cord injury. So we have to open the airway, but with cervical spine protection, we have to do both. So in the first aid situation, we could use the so-called jaw thrust manoeuvre. Now, if you feel the angle of your own jaw there, and go back underneath like that, the jaw thrust manoeuvre, you pull the jaw forward like that, so that like the bottom teeth are over the top teeth. The jaw thrust manoeuvre. It's not very nice to try on your friends because it's quite unpleasant, but you pull the jaw forward and that can open the airway in the first aid situation. And the good thing about the jaw thrust manoeuvre is that can open the airway without having to move the neck, potentially compromising the cervical spine. Anyone who's got a low level of consciousness in the hospital situation really should be intubated. We should establish a definitive airway. And the rhyme here is less than 8, then intubate. So if the Glasgow Coma Scale reading is less than 8, that patient should be intubated to manage the airway, and experienced anaesthetists will be able to intubate that patient while maintaining cervical spinal alignment. So we need to maintain the airway, get the airway open first of all. If the patient's conscious and talking to you, then of course we know that the airway is intact. And we need to assess the airway, get it cleared. So just look, listen and feel for your patient's air coming in and out of the mouth with your hand, or by putting your ear on the patient's nose and just monitoring that and making sure the airway is clear. If not, clear the airway but maintain cervical spine protection. That's the first priority in trauma care. Now the next is breathing and ventilation. There's no point the airway being clear if the patient's not ventilating to get the air in and out. So the diaphragm needs to be going down, the ribs and intercostal muscles need to be going up and out to increase the volume of the chest, to decrease the pressure, to suck the air in. And there's many types of injuries which might stop that happening. So as in any situation, first assess it, look at the chest movements, listen to the air going in and out of the chest with your stethoscope. You can percuss the chest to see if there's any dull areas. You can palpate the chest to see if there's any trauma that you can feel. And there's several classical injuries which can interfere with ventilation. One is a pneumothorax, where air has got into the pleural cavity, causing lung collapse. Another is where several ribs have been damaged, causing a flail segment, and lung contusion under that can interfere with breathing. So we have to make sure that the air is physically going in and out of the patient's lungs. If not, we have to ventilate them using an intermittent positive pressure ventilation system. Now, in a first aid situation, this could just be mouth-to-mouth ventilation. In the hospital situation, we could use the bag valve mask apparatus. And if the patient's intubated, it's particularly easy because we can simply bag those patients. And of course, the other big advantage of intubation, as we mentioned under A, is it is a definitive control of the airway. We can blow the cuff up and protect the airway as well. So if the cuff is blown up on the endotracheal tube, that means if the patient does aspirate and vomit, they're not going to inhale the vomit into their lungs. So the airway is protected as well as being maintained. So airway and cervical spine protection, breathing and ventilation, the next priority. Now after that, the next priority is circulation and hemorrhage control. So we need to make sure that the patient has a pulse. Now in severe injuries, it's good, any traumatised or very ill patient, it's good to feel the central pulses, the carotid or the femoral pulse, rather than the peripheral pulses, because the peripheral pulses can be lost if the blood pressure is a little bit low. When the blood pressure is low, the peripheral pulses go. That rhymes as well. So we can take the central pulses, remembering that when the blood pressure is low, the peripheral pulses will go, so we can assess the patient using the central pulses, making sure there's a circulatory system. We can put on ECG leads as well to monitor the cardiac activity. And hemorrhage, of course, is a constant risk in trauma. The vast majority of patients who are tachycardic, cold and hypovolemic in trauma, the cause of the shock, the cause of the hypotension is most likely to be hemorrhage. It's the most likely cause. Now in trauma there are non-traumatic causes of low blood pressure, but hemorrhage is the most common. And where can hemorrhage occur into? What sort of places are we going to look? Well, hemorrhage can occur onto the floor and 4 more. So onto the floor means it's external, the blood runs out of the patient's body and it just goes onto the floor. Now, when the patient arrives in your care, you may not see a lot of blood on the floor, but there might have been a lot of blood on the floor at the scene of the road traffic accident, or at the scene of the stabbing, or whatever it was. So always check with the paramedics before they go. Was there a lot of blood on the scene? Was there blood all over the car seat? Was there blood on the floor? Try and get a handle on how much blood has been lost. So blood can be lost onto the floor externally. And if patients are bleeding externally, we would normally manage that, at least initially, with direct pressure. In some cases, if there's large arterial bleeding, for example a traumatic amputation, we might want to clip off the bleeding arteries and ligate them very quickly. But in most first aid situations, it's direct, firm pressure can maintain hemostasis, at least for some period of time. On the floor or 4 more. So blood can also be lost into the thoracic cavity, the abdominal cavity, the pelvic cavity, especially if there's associated pelvic injury. So blood can collect in the pleural space, in the peritoneal space, in the pelvic space. So that's 3 more places. What's the 4th on the floor and 4 more places? Chest, abdomen, pelvis. Well, the 4th is from long bone fractures into the limbs. A fractured femur can lose over 1 litre, maybe 1.5 litres of blood from a fractured shaft of femur. So if a patient's broken 2 femurs, you don't need to be a mathematician to work out they can lose 3 litres of blood. This is a life-threatening hemorrhage. So think about bleeding into the long bones. Onto the floor, 4 more. Chest, abdomen, pelvis, long bones. Next we want to think about disability, a nervous system examination. And I think of this very simply in 2 parts. I think of it as brain and spinal cord as being the priority. So is there anything to indicate brain injury? Is the level of consciousness low? Well, if the level of consciousness is low, then we should think of simple things first. Is this patient being oxygenated? So if a patient has a low level of consciousness, let's make sure we're getting some oxygen into their lungs. Or is this patient's brain being perfused? Do they need intravenous fluids to increase intravascular volume, to increase blood pressure? Think of those simple things first. Or alternatively, is there a developing head injury? Is there a hematoma of some sort, an intracranial hematoma? Have they developed an extradural hematoma, or a subdural hematoma, or an intracerebral hematoma that could be interfering with the level of consciousness? Or is the patient concussed? Is there disruption in the axons that communicate between the reticular activating system in the brainstem and the rest of the cerebrum? Just what is it that's going on here? Or, also thinking about the brain, is there lateralizing signs? Has this arm gone weak compared to that one? Or has the right side of the body gone weak compared to the left side? Because if the patient has developed a paresis in the right hand side of the body, if that's become weak, then there could well be a hematoma exerting pressure on the left motor cortex. Think about those possibilities. Then think about the spinal cord. Of course, we need to protect the cervical spine and all of the spinal cord, but is there any indication that there might be spinal cord damage? If so, what level at the spinal cord has this trauma possibly occurred? And under D as well, you could include peripheral nerve damage. Is there damage to peripheral nerves? So airway with cervical spine protection, breathing with ventilation, circulation with hemorrhage control, disability, which is neurological status, then E for exposure, environment, and everything else. Exposure. We need to expose all of the patient because there's a possibility, especially in an unconscious patient, that we miss significant injury. And like me, you've probably been in a situation where a significant injury is discovered an hour after or a day after. You might actually be in a situation where a very significant injury is discovered late because the patient wasn't fully exposed in the emergency situation. Or, when the patient's fully exposed, we might find that they're bleeding from their back or their buttocks and there's a pool of blood developing in the small of their back that we hadn't seen because we hadn't exposed the patient. So look at the full surface area, so full body surface of the patient, assessing for hemorrhage and other injuries. But when we expose these patients, we also need environmental control, because we do not want traumatised patients to become hypothermic. Why is it so important that traumatised patients do not become hypothermic? Well, if patients are hypothermic, that is going to interfere with the ability of the blood to clot. The coagulation cascade that causes blood clotting depends on enzymic systems. And enzymes, as you remember from very basic biology, are temperature dependent. Enzymes will only work at physiological temperatures. So as the body temperature starts to drop, the efficiency of these enzymic systems will be reduced and blood coagulation will be inhibited. So if you expose your patient, you let them get cold, the blood will not clot properly and any hemorrhage will be exacerbated. So don't let them become hypothermic. Environmental control. And E also stands for everything else. So E stands for exposure, environment, and everything else. And a common thing under the everything else category that you might want to check is the patient's blood sugar levels, for example. That's always worth keeping an eye on, that the patient's not something as simple as as hypoglycemic. So that's the priorities of care in the trauma situation. A, B, C, D, E. Life-threatening conditions are identified and managed simultaneously. Once that's done, you can then go on to the secondary survey, which we're going to talk about after this.